155/85, third visit in the row like that. She tells you flatly, no more pills, she's already on 3. Before you reach for a 4th drug, there's a checklist most people skip. And skipping it is how resistant hypertension gets diagnosed in someone who was never actually resistant to begin with. So confirm it is real before you treat it as real. Hypertension. Thresholds, first line selection by compelling indication, and how to actually confirm resistant hypertension. Stage 1 is 130 to 139 over 80 to 89. Stage 2 is 140 or 90 or higher. But the treatment threshold isn't just a stage, it's the stage plus risk. Clinical CVD or ASCVD risk 10% or higher drops your threshold to 130 over 80. Stage 2 and more than 20 over 10 above goal. You want to start 2 drugs from different classes on day 1. Not 1 drug, wait, and then see what happens. So stop treating first line selection like a coin flip. Match the drug to the disease. Diabetes or CKD, you want to use an ACE inhibitor or ARB, especially with albuminuria. Oh, I always watch that. Reduce or preserved ejection fraction heart failure. Your options are an ACE inhibitor, ARB, or an ARNI, layered with a beta blocker, a MRA, or a diuretic. If there is no compelling indication and the patient is Black or African American, you want to use your thiazide or your CCBs. These 2 are actually more effective than an ACE inhibitor or an ARB in that particular population. This is guideline backed. This is not a preference. More resistant hypertension isn't actually resistant. Step 1, you want to rule out pseudo-resistance, whether it be a bad cuff technique or the white coat syndrome effect, and if the patient is just not adherent to their medications. Step 2, you want to see if there's any contributors and reverse those contributors. Is the patient on any NSAIDs? Is the patient someone who suffers from increased alcohol intake, any stimulants? Is the patient on any oral contraceptives? And only after that you do screen for secondary causes and escalate pharmacologically, maximize the diuretic first, chlorthalidone or indapamide, and then add an MRA. Now, pregnancy changes everything. Methyldopa, nifedipine, labetalol, those are your options. ACE inhibitors, ARBs, aliskiren are contraindicated. These agents may cause fetal defects. And if you are at reproductive age, a patient on an ACE inhibitor and planning pregnancy, that switch should happen before conception, not after a positive pregnancy test. Now going back to the patient, her name is AM. This patient is a type 1 diabetic with hypertension on 3 antihypertensive plus an estrogen-containing contraceptive. The BP is still 140 over 83. The highest yield move isn't drug number 4, it's the contraceptive. Estrogen actually increases blood pressure, so that would be something that you would switch first before considering adding on a 4th blood pressure reduction medication. Thank you for listening. That concludes this section. Stay tuned for section number 4, where I will go over dyslipidemia.